I appreciate the opportunity to share with you something I've been very involved with as an ethicist, and frankly, so important is this to me that I'm really have become more of an activist than an ethicist in this point of view. And you'll hear about my point of view, but I think it's important that you all understand what's happening here in the U.S.
I would love to be the
Because
Surgeon General.
our
That's something I would
our
leave my job
practices
for.
here. And if I can ask people to please mute themselves because I hear a couple of people coming through there. Thank you. That what we are have been doing here really for almost 30 years now, going back to the Oregon origins, resembles much more what you all are proposing to do in the UK, in England, much more than it resemble than your practice resembles what's happening in Canada or Benelux. You know, to paraphrase Santayana, who said, those who do not learn from the past are doomed to repeat its mistakes. We represent here the past, and I hope to give you lessons that you can use as you go into your future, as you're facing this very critical turning point in what might be a new era of medical ethics and practice in the UK should these couple of laws get passed. So Bob Dylan famously sang, "The order is rapidly fading, for the times they are a changing." And they are changing indeed. The pandemic, I think, supercharged that transformation. We see all sorts of things that have been going on here really in the last 20 years that have been profound changes in the psychosocial and ethical landscape, and particularly the medical ethical landscape here in the United States, that has really been, frankly, can produce a great deal of moral vertigo. And if you all are following some of the latest developments in the last couple of months here in the United States, it really, the practically catastrophic, enormous changes that are happening in our government here have really taken a vertiginous situation and elevated it into a staggering one. So tremendous amount of changes, and I think that our topic today really fits in to that very rapidly changing, dizzying zeitgeist that's happening now in the world. So let's begin off with some terminology, just so we're all utilizing some of the same uh, language as we speak, although language is a bit fluid in this. The term has emerged recently, and I think Canada has been influential in this, called MAID, Medical Assistance in Dying. And that's a term catching on worldwide. It's a term that's somewhat problematic, as we'll soon see, but let's just unpack what's understood in this term. There are really two different notions here, uh, two terms of art, if you will, that have become generally accepted. One is physician-assisted suicide. And physician-assisted suicide involves procedures for people generally that are terminally ill, although in some countries not exclusively, where a doctor or other designated healthcare professional, in some places mid-levels, can write a prescription to have dispensed to the patient a cocktail of lethal medication that they self-administered at the time and place of their own choosing, with or without any kind of supervision, usually because there is no set time and place. The medication gets stored somewhere, who knows, hopefully not in the closet discovered by the person's suicidal grandchild at some point. But it is an orally administered, self-administered paradigm. Now, in addition, under MAID comes the term euthanasia. Euthanasia refers to, again, a physician ending a person's life, not by getting out of the way of death, but by administering it with an intravenous lethal injection. It's so there's a clinician at the bedside at a planned time and obviously is supervising what's going on. So the term MAID includes physician-assisted suicide and euthanasia, and some people would like to shoehorn into this palliative care. But palliative care really is not considered part of MAID. And as a matter of fact, as we'll soon see, many palliative care organizations are actively resisting efforts to try and create a broader umbrella that includes these two things plus palliative care. But in fact, many palliative care specialists really do not want to be identified with either of these for various reasons. So in terms of those two different approaches, in the US, we have strictly physician-assisted suicide. We do not have euthanasia, unlike Canada, unlike Belgium, unlike Luxembourg, unlike Belgium, which have predominantly euthanasia. We only have physician-assisted suicide so far here in the United States. Now, I do want to, since we're on terminology, I just want to make a couple of reflections here. Many of you know your British author, George Orwell, in his book 1984, famously said, if thought can corrupt language, language can corrupt thought. And indeed, it works both ways. So the words that we choose to use can very much influence how we think about things. So we have made medical assistance in dying. Many people who are concerned about this and opposed to this want to utilize what they feel is a more honest term, which is MAD, medical administration of death, because that's what we're talking about, either by providing people a chemical gun, as some people have called it, with which to, shoot themselves with handfuls of lethal medication, or with an IV administration, as in some of these other countries. We are administering death here, so maybe made or mad, depending on your point of view. As with many of these controversial things, such as abortion, for example, the different sides come up with different language to try to emphasize what they want to be seen in those practices. Now, here in the US, our CDC, the Centers for Disease Control, which is our government epidemiological agency, has defined suicide with the common sense definition, death caused by a self-directed behavior with an intent to die. And now we're in my wheelhouse as a psychiatrist. This is, my bread and butter of my professional life is suicide. And so ordinary definitions of suicide really do cover what we're talking about here. We're talking about patients who, with legal permission, are asking their physicians to provide aid and abet them to commit suicide, giving them the means to do so, providing that indirectly with pills or directly with intravenous. The editor-in-chief of the Journal of Ethics and Mental Health, in Canadian, John Mayer, said, using the term MAID is an attempt to separate suicide from its value-laden meaning and thousands of years of moral reflection. MAID is a species of suicide. And as a matter of fact, one of the problems is that these kinds of laws set up two different tiers, two different kinds of suicide, sort of the bad suicide and the good suicide, the suicide that we should prevent, which is our public health measures, as well as my individual work with patients in trying to prevent suicide in my work as a psychiatrist. But then now these kinds of laws set up a domain of people for whom we should provide suicide. And with the first group, we call those people suffering a pathology when they are thinking about wanting to end their lives. But in this more privileged group, we have somehow labeled this as a medical treatment and medicalizing it. So this creates a great deal of confusion. And in fact, study after study have shown that it really is not possible to parse and discern those who belong in the first category from those who belong in the second, those for whose suicide we should work to prevent, and those for whose suicide we should actually provide. Now, our American Association of Suicidology at one point in 2017 declared legal physician-assisted deaths should not be considered to be cases of suicide. So they wanted to bend the common sense definition of suicide. But in fact, uh, that turned out to be a largely politically and frankly donor-driven move, not a scientifically based move. And over the course of the next several years, by 2023, the clinicians and the scientists in the organization really made the case that, again, you cannot discern these two groups, who should be provided and who should be prevented suicide. And so in March of 2023, this organization retired or retracted this assertion that we should not consider physician-assisted suicide as, quote, suicide in the conventional sense. They've realized that it really is folly to try and parse those two. And while we're on the subject of terminology, the question is the medicalization of this. Is this healthcare? Very interestingly, over there in the UK, the last week, just a week ago, there was the annual consultants conference for the British Medical Association, where they gather all the consultants together to determine what the positions of the medical association is. And they have declared assisted dying is not a health activity, and it must not take place in the NHS or other health facilities. That this does not belong in the House of Medicine, says the British Medical Association. All right, let's come back across the pond to the United States, which is our primary focus today. And let me tell you a little bit about what's going on here and how it has been deployed and evolved and some of the problems that we've seen. To begin with, I want you to understand the basic notion here in the US of federalism. So federalism, yes, we're a nation, a unified United States, but we're also a collection of 50 different states. And there is a dynamic legislatively, legally, between laws that are federal top-down laws that apply to all states and bottom-up laws that are implemented by the states and certain rights reserved for the states. And in healthcare, a number of healthcare laws and practices actually are articulated by the states. And so it can be very different in different states. So to understand what's happening here in the US, we really have to look at this at the level of states, because that's really where the action is. And that's true with other healthcare issues, such as abortion, for example, transgender medical care, and so forth. It really is more a state-by-state basis for most of these things. So here in the United States, we have 11 jurisdictions, 10 states and Washington, D.C., which is not formally a state, that have some legalization of physician-assisted suicide. Remember, not euthanasia, but the oral prescription and self-administration. Oregon was the first back in 1997. So if you notice, of the 50 states, we only have 51, if you include DC, only these 11 jurisdictions. So I don't want you to think that this is a very popular, extremely widespread practice in the United States. It's actually a small minority of states over the course of nearly 30 years that have legislated this. And many states, advocates, have reintroduced bills to try to legalize this in their states. Many times here in my state, Maryland, I think it's been introduced about 6 times and failed to pass. I believe in New York, they're up to 14 attempts now. So it is not a foregone conclusion. This is not a robust, widespread practice in the United States, but it is in these states, and we'll take a look at what's happening in some of those states. Now, there have actually been no states that have legalized it since 2021. But in 2023, though Nevada and Delaware both passed, the legislature passed laws, the governors of those states that needed to sign off on those laws vetoed the laws. So they did not actually enter into formal law. Now, in 2025, we have, and this is not unusual most years, about 14 states with legislation pending. And we have 4 states, Vermont, Oregon, Washington, and California, where there's already legalization of these practices, but there's legislation pending to expand those practices. And we'll get to the whole subject of the expansion of these laws once they are struck. But I also want to let you know that because the minority of states do this, there are some states that not only have failed to pass these laws, but have actually passed resolutions or laws inoculating themselves to prevent the introduction of such legislation in the future. For example, in 2017, South Dakota legislature passed a resolution that the legislature strongly opposes and condemns physician-assisted suicide, and they say we do not welcome the introduction of any bill of that nature in this state. 2018, Utah, the governor signed into law specifically an expansion of the definition of manslaughter to include intentionally and knowingly providing another with the physical means to commit suicide, i.e., that includes physician-assisted suicide. So that is now, since 2018, not only forbidden, but it is frankly illegal. In Indiana, in 2024, the Senate passed, again, a resolution opposed to this. And I think the language in that resolution is poignant. They say assisted suicide eviscerates efforts to prevent the self-destructive act of suicide and hinders progress in effective physician interventions, including diagnosing and treating depression, managing pain, and providing palliative and hospice care. So not only did they oppose it, but they opposed it for very specific and I think well-articulated reasons. In this national election we just had in November, West Virginia narrowly but successfully incorporated at the highest level of prohibition. They put into the Constitution of the state, which is something that's very difficult to implement and conversely very difficult to overturn. They have made a constitutional provision in the state of West Virginia prohibiting physician-assisted suicide. Montana is an interesting state. Now, Montana, back in 2009, they said that basically we will not prosecute any physician who is a well-intentioned physician who administers assisted suicide to their patient. But now, as of just last week, March 7th, they've introduced a bill to try to reverse that. So an act providing that consent to physician aid in dying is not going to be a defense anymore to a charge of homicide. So that's now currently being debated, and it's largely expected to pass, thus reversing. So Montana doesn't have a specific law that outlines, as we'll see in a moment, all the different approaches to how to evaluate patients. They just say you can't be accused of homicide. Well, now they're trying to reverse that. And at the federal level in 1997, Congress, the United States Congress, passed an act that prohibits the use of federally appropriated funds for causing or assisting in suicide, euthanasia, or as they call it, mercy killing. So, and that is still on the books. That's still a law that prohibits the use of federal funds for these things. So where it's happening in states, it uses state funds. All right, let's take a look at some of the basic statutory requirements that go into many of these laws. Typically, they apply to terminally ill patient, although they don't define what terminal illness is. And oftentimes these laws do not specify whether terminality means an illness is expected, death is expected in 6 months with treatment or without treatment. It can actually, it's somewhat ambiguous. It can, in many states, it can go either way. And the current status quo of medical ethics, which is the right to refuse treatment if you're a person with capacity and competence, that continues to adhere. So you may refuse treatment and thereby convert a non-terminal illness to a terminal illness, such as deciding in end-stage renal disease that you don't want to have either a kidney transplant, renal transplant, or dialysis. thus now converting yourself into a terminal illness that will allow you to be eligible. Typically, a written request is required with two witnesses, but one of those witnesses, if you wish, can be a relative, including somebody that may stand to be an heir to inherit from you. Two doctors must evaluate both the diagnosis, prognosis, and whether or not the person has capacity. We'll get back to that issue shortly. If the evaluating physicians believe that there's a psychiatric issue afoot, whether that's a psychiatric illness or a problem with capacity, then most places require you to refer to a psychiatrist. Hawaii is an interesting exception. In Hawaii, every case must be screened by a mental health professional. However, the mental health professional does not have to be a physician, a psychiatrist. It can be any licensed mental health professional. So that can include psychologists, social workers, addiction counselors, family counselors, educational counselors. As long as you're in a category of mental health professional, anybody can do the screening for either mental illness and or capacity that is required by law there. The only state that actually requires every case, but again, not necessarily people who are entirely qualified to do that screening. Patients must be informed about the alternatives. The standard waiting period is a 15-day wait between a written request and being dispensed, the lethal cocktail, but we'll see there have been shortenings in that interval. Telehealth evaluation and prescription is explicitly allowed in Vermont and Hawaii. It is not forbidden in other states, and in Oregon and Washington, they actually have been allowing telehealth evaluation and prescribing of lethal meds. And in most states, you have to be a resident of the states, with two exceptions, as we will see, in Oregon and Vermont. So what is used? Well, this is the lethal cocktail. Some people call it a cocktail. Other people call it a chemical gun. And you can see the various components, and this has evolved over time that go into this. This is sort of the current formula that's being used in most states, particularly in those that have been at this for a while. Now let's turn our attention to Oregon, because Oregon was the very first place that this became legal in 1997. So we have the longest experience here, the most data collected. So we'll be looking at a lot of the data that's come out of Oregon, because it is the most studied, and also it has really been kind of the template, the model on which most other states have built and based their laws. And as a matter of fact, quote, the Oregon model is something that is now discussed worldwide, and it has come up in testimony in the Ledbetter bill and the testimonies. So many other countries look to, quote, the Oregon model. So we're going to take a particularly close look at Oregon. So between 1998 and 2023, there have been a total of over 4,000 lethal scripts written that resulted in over 2,800 deaths. You can see that this has really been increasing, and it's taking sort of an exponential term. In fact, in the last 3 years, there's been a 50% increase. But I want you to note that there's a difference between the scripts that have been dispensed and the scripts that are used. In fact, that of the dispensed scripts, only about 2/3 get used, and the others remain unused. Many people have called it a security blanket that people can hold on to in case they need it. Now, this is incomplete data, because in 2023, about 1/4 of all the scripts written, we have no idea. The outcome has been inadequately tracked. We don't know if they were used, unused, what's happened to it. Other interesting data from 2023, in almost half the cases, no physician was present to witness. So we have no idea what was happening, whether there was coercion going on or not, because physicians are not required anywhere in the United States to be present as witnesses. For 42%, because there's been a change in the law, which I'll tell you about, there was no waiting period for, so in 2023, 42% of all physician-assisted suicides were given the prescription was written and used the same day as the patient was evaluated. And there's been, about 10%, 9 or 10% complication rate. So what happens to all of these unused medications? Where are they? We do not know. We do not know, because they're not tracked. We don't ask for them back. They're not returned to the pharmacy. They could be, as I said, stored in the closet for anybody to come along and try to investigate or use, sample. And there have actually been a couple of misadventures where that's occurred. We do know in one case, the pills sat around for over 4 years before they were finally used. And as I said, it's in terms of eligibility, the Oregon Health Authority has affirmed, this is a quote from the Oregon Health Authority, who said patients may not be able to afford some treatments. If the patient doesn't receive the treatment or medication for whatever reason, whether they don't want it, they can't afford it, they can't find it. And I'm going to ask you to please put yourself on mute, and is left with a terminal illness, then he or she would qualify. So it doesn't matter whether you, how you end up not getting treatment doesn't matter. If you are deemed terminally ill, then you qualify. Now, who is prescribing these? So in 2022, there were over 6,500 doctors in Oregon. Of those doctors, only 2% were interested and willing to write these lethal prescriptions, 431 lethal prescriptions. Most of those doctors, 146 doctors, wrote one at the most 2 scripts, but one doctor wrote 51 and 3 doctors wrote 86. So a total of 4 doctors accounted for about 1/3 of all the lethal scripts that were written in Oregon. So there is a tendency when these laws are enacted for most physicians to shy away from this on one hand and it to agglutinate around a few very zealous, committed, passionate physicians, some of whom end up devoting their entire practice to just specializing in the evaluation and administration of these procedures. Here's one example. This psychiatrist, as a matter of fact, for $5,000 in Oregon, terminally ill patients could book a death that might look a lot like a wedding package. Patient would check in at 3 p.m. They have music, flowers, catering. They can bring as many family members as they wish, their pets, their attorney. That flat fee includes catering, security, videotaping, music, flowers for an extra $1,200, 3 hours of psychiatric help from him and his therapy dog. So here's his therapy dog. By the way, this was published in the news, and a day later, the medical board suspended this guy's license. But in point of fact, we see the development of kind of a cottage industry, a cottage death industry that is happening in states that have been at this for a while. It's especially true in Canada, where funeral homes now in Canada, where they have euthanasia, have an entire line of service that's available now, where they have a euthanasia suite, and they provide many of these same services. So the point is that it does invite a certain degree of zealotry and opportunism for this. So in Oregon, again, where most of our data comes from, who is receiving these procedures? Well, really, they say the demographics are the 3 W's: white, well-off, and well-educated. So the people who have been getting this in the last couple of decades in Oregon, 96% of them are white, even though Oregon population is only 76% white. So it's preferentially white. Well off. So almost half of people have private insurance. And if you have private insurance in the US, it means that you are employed or that you are well off enough to purchase privately your own insurance. And well educated, that of the people who receive assisted suicide, 74%, three quarters, have some college education or higher, whereas the total population of Oregon, only 30% of the population have some college or higher. So again, it's an enriched population of well-educated people. So these basically are the population of people who are generally privileged and used to being very effective and active agents in their lives, and much more likely than other sectors of the population to be able to get their way. We've also seen over the course of these years, 2016 to 22, the median number of days between the request for the cocktail and the administration of and taking the cocktail has been getting shorter and shorter and shorter. So at first, people were much more reluctant and much more conservative. And as this has accelerated, just like the number of people has accelerated, similarly, the pace at which it's being done and the interval between the request and the fulfillment of that request is becoming shorter and shorter. Now, patients are asked as part of the evaluation why they're interested in having physician-assisted suicide. And here are the top reasons, according to Oregon's Health Authority report, that people are saying they want this. They cite their fear of losing autonomy, developing a state where they can't engage in their activities, a fear of losing their dignity, being a burden to their family, almost half of them, the fear that they're going to be in pain, the fear of the cost of care. Point is fear. Fear is a very big driving force for people, and anxiety. And I want to note that this is something that is very much in my wheelhouse to minister to, which is dealing with people's fears. But psychiatric intervention, evaluation, the option to work with those fears is not at all built in statutorily to most of the laws, particularly not in Oregon. Just a small note on California. Uh, California has also, seen a significant rise just in these 1 year, 21 to 22. They had a 63% increase. Again, there's a gap between the prescriptions written and the prescriptions used. In California in 2022, which is the latest data I have, 43% of the prescriptions were unused. Again, sitting around, who knows where, who knows who has access to them. Now, it's interesting because as I told you that many states, are pushing back against this with various resolutions and inoculations. But even in those states where it is legal, such as California, there are also internal pushbacks in those states. So 61% in 2019, which is where this data comes from, 61% of hospitals in California have policies that forbid the writing of assisted suicide prescriptions by their staff. Interestingly, and perhaps not surprisingly, these hospitals are more likely to have palliative care options for patients, to have end-of-life training for those clinicians to know how to minister to patients in a variety of ways that may actually not help the patients think alternatively from assisted suicide. They tend to be nonprofit hospitals and are more likely to be religiously based than those hospitals that allow those prescriptions to be written. All right, so let's look a little bit more about some of the problems and expansions as these laws have come online and been released. When the horse gets out of the barn, it bolts away and quickly finds its way to further pastures, and it's very difficult to get it back into the barn. Let's see how the horses of assisted suicide have strayed and bolted, and some of the places they've gone since they were first statutorily legalized. So first, some of the problems with the guidelines as they've come out in these various states. So I've already mentioned that except for Hawaii, no state has a requirement for any psychiatric assessment as part of the treatment, as part of the evaluation, or treatment, to give a mental health professional a chance to work with somebody to see if indeed we can find a path to a different future with them, except Hawaii, where any mental health professional just has to sign off you don't have a psychiatric illness and you're not incapacitated. There is no requirement in any jurisdiction for any attempts at palliative care. There's no minimum time for an established doctor-patient relationship. And in fact, in Oregon, the data shows the shortest relationship, actually, I say 4 days. It's now down to 1 day. You can meet a doctor that you never met before, and that doctor can evaluate you and give you a lethal prescription with a doctor-patient relationship that may only be hours old. Patients can keep shopping if a physician, their own physician or a consulting physician is not agreeing to sign off on it. You can keep shopping till you find one of these perhaps more zealous physicians who has a unique practice devoted to this. If you have a second opinion, where second opinions are necessary, that second opinion can be a clinician, a physician in the same practice. So, there could be a conflict of interest. You refer your patient to your partner who's in your same practice. It might be much more difficult for that partner to disagree with you. There's no prohibition against that. There is no requirement in any state that you must consult a specialist in oncology, a specialist in pulmonology, who might be able to look at treatments that may not have been tried or may be more accurate prognosticator. No requirement. If you're being treated by a generalist, that's fine. You don't have to consult a specialist. There is no requirement for any formal assessment of capacity or any training in capacity assessment. And we're going to get back to that point in a moment. And in most states, when you report out the death certificate, you are not allowed to put as the cause of death physician-assisted suicide, lethal cocktail. You must report as the cause of death the illness, the terminal illness that qualified the patient for this procedure. So therefore, there's not necessarily an accurate way of tracking how many deaths in these states are actually due to assisted suicide. There are no mechanisms to assess coercion other than a physician's interview of the patient or their family. Physicians really who are not trained or qualified to really assess the complexity of a psychosocial situation to know whether or not there's a coercive element here. There's no requirement for a witness to the final act. So even though euthanasia is not allowed, people, and if euthanasia is assisting the person, a person who's incapacitated, who can't self-administer, there's nothing to prevent other than the legal prohibition, but they're not witnessed, nothing to prevent whoever is standing at the bedside to administer euthanasia. And it's available to people in coercive environments like terminally ill prisoners, for example. There is no statutory way to define the difference between encouragement and coercion. No clear boundary between them. No clear boundary between, grandma, this would be good for you, and grandma, you promised you would do this, and you're strong, you can fulfill your promise. One author wrote, "How thin and porous the border between coercion and free choice is. How easy it is for someone to inadvertently influence you, to feel devalued and hopeless, to pressure you ever so slightly, but decidedly into being reasonable, to unburdening others, to letting go." We talked about how patients become unterminal is unregulated. You can make yourself terminal by refusing treatment. This is true in every jurisdiction here. And as we've talked about, there's no provision for the storage and monitoring of the medications. In terms of implementation, the Disability Rights Education Defense Fund has looked at a number of anecdotal reports of problems in Oregon, because again, we've had almost 30 years of experience with some of the ways things are going wrong in Oregon. I'm not going to articulate these things. You can see them on the slide here. And you can go to the website of this organization to look at many examples of some of the misadventures in the implementation of these laws. Now, I told you about this lethal cocktail that they have in Oregon. I want to point out that this cocktail was developed over 7 years. There were 4 different cocktails tried, and no research protocols were implemented. There was no ethics committee review, no internal review board, no protocols. This was just trial and error experimentation in the wild, not in any way conforming to the standard ethical guidelines that we have in this country and in the UK as well for human experimentation. This was all off the books trial and error. And it doesn't always go well. A number of cases where people have suffered seizures, protracted vomiting, and this is in Oregon, 2023, 9 patients awoke after taking their box of all of these medications, and believe me, it's a box full. And after having survived it, none of them wished to repeat it. They all changed their mind. It reminds me of some patients that I've worked with in psychiatry who have jumped off bridges in an attempt to suicide, and they've survived. And universally, they have regretted the attempt. Now, what about referral for psychiatric evaluation? So, most of these laws say if in the opinion of the attending physician or consulting physician that someone's suffering for psychiatric disorder or depression causing impaired judgment, then you shall refer for counseling. So it's got to be in the opinion of the consultants. Well, in Oregon, the first year this happened, people were, very careful and not sure of themselves and not sure that they were, properly prepared to make that evaluation. So about 1 out of every 3 people were referred for psychiatric evaluation in the first couple of years. But you can see that afterwards, the rate became negligible. Between 2000 and 2008, basically it dropped to 0, picked up a little bit thereafter. In 2023, there were only 3 people in all of Oregon referred for a psychiatric evaluation. Michel Montaigne said, "He who fears shall suffer, already suffers what he fears." And I think that that's true. We talked about fear. This was a study in which they took people in Oregon who had already been dispensed lethal medications by the 2 evaluating physicians and agreed to be interviewed by psychiatrists. And the psychiatrists found that 31%, nearly 1/3, they believed had clinical depression that was unidentified by the consultants and untreated and should have been a signal for a psychiatric evaluation. Interestingly, those patients, once they were determined to actually be suffering from potentially treatable clinical depression, were offered free psychiatric treatment in order to deal with their depression. And of the 13 people who were discovered to be in that category, only 1 decided to avail themselves of that treatment. The others had made up their mind. They didn't want to deal with that offer, and they went on to use their lethal medications. Now, one of the things that physicians have to determine is whether a person has capacity, has competence. Well, I want to tell you that the skill set for evaluating competency and capacity in people is a highly specific and rigorous skill set, and not even a skill that all psychiatrists have. They typically, the subspecialists of forensic psychiatrists and so-called consultation liaison psychiatrists who do consultations in general hospitals on general hospital patients have the training to do that. I am neither of those. I myself as a psychiatrist of 35 years, do not consider myself qualified to do a proper capacity evaluation. Well, here is the template developed by the American Association of Forensic Psychology for going about a detailed evaluation of competency for something far less irreversible, which is the competency to stand trial. And it goes on for pages and pages and pages of all the considerations and points of view and issues that have to be reviewed. In contrast to that, this is the form that Oregon physicians must fill out when prescribing physician-assisted suicide. And there are a bunch of check boxes, and one of the check boxes is check, determination that patient is capable. And there's a little asterisk there, and at the bottom of the page, the asterisk says, capable means that in the opinion of a court or in the opinion of the patient's attending physician or consulting physician, a patient has the ability to make and communicate healthcare decisions to healthcare providers. So that's all you got to know. Do you think they have capacity? In fact, there's there's a YouTube of a physician who's very involved with this, one of the zealous physicians in Oregon, who says, if I ask the patient a series of questions and ask them to respond yes or no, if they don't have speech, if they can just wave their little finger, yes or no, that's good enough for me. That is not what we consider the standard of practice of evaluating for capacity. But again, you're not required to see any kind of an expert, nor are these evaluating physicians required to get any kind of specialized training in the evaluation of capacity. Incidentally, just as an aside, here's the capacity assessment report form in Ontario. Just 4 yes or no questions, and you're done. So we're beginning to see the short circuiting, for probably economic motivations to assisted suicide. In this particular case, a professor of internal medicine tried to transfer 2 patients from Nevada to California and Oregon for medical procedures not performed at his hospital. Representatives from 2 different insurance companies denied those transfer requests by phone. He said, in both cases, the insurance medical director said, we're not going to cover that procedure or transfer, but would you consider assisted suicide if we transfer to those states? Because California and Oregon have it, Nevada doesn't. So they were willing to pay for the assisted suicide, but not for the far more expensive and requested medical procedures. All right, so what happens when you strike these laws is they almost inevitably expand. When the assisted suicide laws run out against a boundary that's supposed to hold it, that boundary invariably yields for understandable reasons, because the principles of justice and fairness, so we sometimes use the word parity so that everybody, has an equal chance. Wherever you draw the line, the people just on the other side of that line will understandably say, but it's not fair. It's not just. You said 6 months prognosis. Well, what about 7 months prognosis? You said people who are suffering from physical illness. What about us psychiatric patients? You want to treat us with equanimity and parity. It's not fair that you are allowing it for some medical conditions, but not other medical conditions. So it's very, very difficult to hold a boundary line wherever you draw it. So we have seen, after the initial laws, expansions in a number of states and another number of areas. So after the initial laws, several states have expanded from MDs to being able to do these evaluations and prescriptions to mid-level nurse practitioners and physician assistants. Some have added on telehealth to evaluate and prescribe. There have been a number of states that have reduced the waiting period from between request and prescription from 15 days to 48 hours. And in Oregon, now if somebody who's considered imminently terminal, there is no waiting period, 0 days. As I said before, you can make the request, meet the doctor for the first time, make the request, get your prescription all in the same day. And there's been the elimination of state residency requirements in two states, Oregon and Vermont. In 2022, in Oregon, in 2023, 6% of the assisted suicide cases in Oregon were non-residents. New Jersey attempted to pass it, to extend it, excuse me, to eliminate the residency requirements, but that failed in the legislature. But they are trying again. Remember, it keeps coming back and back. So, de facto, if not de jure, if you are capable of traveling to any one of these states, you can get physician assisted suicide if you meet the requirements. Therefore, de facto, these procedures are now actually available to all American citizens. Now, we have also seen the beginning of the era of psychiatric euthanasia, assisted suicide coming into the United States. So in February 2022, this clinician published this extremely controversial cases where she asserted a concept that is not an accepted concept in the specialty world of eating disorders of terminal anorexia in Colorado. And she decided that 3 of her eating disorder patients, even though psychiatric patients are supposed to be excluded, they're not explicitly excluded in Colorado. She felt they met the criteria of having a futile terminal illness, and she provided 3 of her patients prescriptions for lethal medications. 2 of them used it, but 1 of them died before it could be used from her anorexia. The remarkable thing is, now that this precedent is established, we have now seen several defense attorneys in Colorado when anorectic patients come up for an involuntary commitment hearing to be committed involuntarily to the hospital. One of the criteria for involuntary commitment is that you have to show that the plan is the least restrictive alternative. And based on these cases, some defense attorneys have now been arguing on this precedent in Colorado that providing assisted suicide constitutes a lesser restrictive alternative to actually involuntary hospitalization. They have not been successful in that argument, but they're making that argument. Now, this organization, Compassion and Choices, is the most organized, well-funded, and effective advocacy organization for getting these laws passed in the US. And their strategy is the low-hanging fruit strategy. They try to effectuate the introduction of bills for cases that might be the least controversial, the cases of people who are, clearly terminally ill and suffering. But as they have articulated, that is the foot in the door to, the easiest low-hanging fruit, but their agenda is far more serious. So their main intellectual arbiter there is this ethicist Thaddeus Pope, who's their advisor, who has published their agenda here in the US. And some of that agenda is already being fulfilled. Permit non-physicians to prescribe lethal meds. Well, after you initially start the law to permit physicians to do it, that's been accomplished in several states. Shortening or the waiting period after the initial law, that's been accomplished. Dropping residency requirements, that's been accomplished in a couple of states. Permitting approval by telehealth, that's been accomplished. Also on their agenda is permitting others who can't self-administer to take the oral meds. On their agenda is eventually permitting euthanasia, allowing advance directives, and several other points that is on this very relentless agenda. And again, Compassion and Choices is highly funded, extremely coherent, frankly, much more coherent than any of the forces in the US that are opposing these laws, and are also very highly endorsed, as well as sponsored by many famous celebrities. So what's the future here in the US? Are we going to become like Canada or Netherlands or Belgium, Will physician-assisted suicide eventually give way to euthanasia? Will our restriction to non-terminal terminal illnesses become also eligibility for non-terminal illnesses, as in those other countries? Will the restriction from administering these for psychiatric disorders start to become available for psychiatric disorders? Well, those of us who are watching closely, we predict the eventual evolution to all of these things in the United States, because in every living laboratory around the world that has been at this, the data suggests that this is an inexorable journey. Because what happens, and what's happening in this country, the more we practice this, and the more states that come online, we get desensitization to assisted suicide, and we struggle with the unfairness of limiting to terminal illness, and our legal principles of parity and equal protection that don't want to have excluded groups. When you start to say, okay, this group can have this privilege, but that group can't, we're in particularly difficult legal grounds. So the future of what's happening in the United States is very vulnerable. And we see things here that, the atmosphere in this country also may be an accelerant. So here during the pandemic, the Texas governor said old people should volunteer to die to save the economy. And that lots of grandparents would agree, let us die so that, our children and grandchildren can live. So there's a developing zeitgeist. And as a matter of fact, here, our de facto, not de jure, co-president, if you've been reading about this fellow, Elon Musk, who is radically dismantling the federal government here and causing a level of anxiety. And let me tell you, as a practicing psychiatrist now in these last couple of months, the temperature of my psychiatric practice has never been as hot as it is now since the 2 months following 9/11 in this country. But Elon Musk just last week said the fundamental weakness of Western civilization is empathy. So these are some of the guiding principles that are coming from the top-down leadership that I think will also be an accelerant to these developments that I am predicting. Incidentally, I just wanted to mention that, oftentimes, people say, well, look, we palliative care can be a good alternative to this, which I think it can be. However, in this study in 2019, if you look at U.S. hospitals with greater than 50 beds, so those are, hospitals of medium to large size, 1 out of every 4 of those hospitals have zero palliative care services. Palliative care is unfunded, unavailable in many jurisdictions. Physicians are not trained in it. We do not have enough palliative care to go around. And certainly it's much less expensive to short circuit with assisted suicide. Now, what do professional organizations in the United States say about it? Well, the AMA has consistently said that these practices are fundamentally incompatible with the physician's role as a healer. In fact, they've taken 4 deep dives into this, 4, most recently in 2018, where they've looked at it with constituents, stakeholders, professional ethicists and philosophers, theologians and clinicians, and they have repeatedly come to this same conclusion 4 times. American College of Physicians agrees it does not support legalization of physician-assisted suicide. The American Psychiatric Association, you heard at the beginning, we hold with the AMA all of our ethics, but we made a special statement specifically designed to be heard in Belgium, Netherlands, and Canada with regard to non-terminally ill people, because that's the category in which our patients are in, that it is not ethical for a psychiatrist to prescribe or administer any intervention for the purpose of causing death to those people. The American Academy of Hospice and Palliative Care Medicine is very, very reluctant to see this as part of palliative care. Matter of fact, here are a number of professional medical organizations, and a number of them have either explicitly opposed to these procedures or will acknowledge them without opposition. And at the best, they have what's called studied neutrality. Not one organization has endorsed these, and a number of them have opposed both assisted suicide and euthanasia. Now, you remember I talked to you about the two tiers of suicide, the suicides we should prevent and the suicides that we should provide. Providing suicide and calling it a medical procedure is really problematic. It's a kind of moral outsourcing because it moves the responsibility for suicide to the physician. Uh, it is a socially forbidden act. It is a taboo, and frankly, the taboo is important as part of suicide prevention. Not stigma. Stigma and taboo are different things. So when you take away the taboo by calling it a medical procedure, uh, you actually throw a tremendous wrench into public health efforts to discern the difference between these two and to try and prevent suicide. And interestingly, there's even some evidence there may be suicide contagion by virtue of having a domain of acceptable suicide. Not just acceptable, but romantic stories of beautiful parties at the end of life. Look at this. Over the time that Oregon has had assisted suicide, the increase in the suicide rates, general wild type suicide, if you will, in the United States increased by 28%. Whereas in Oregon, over that same period of time, the suicide rate increased by 50%. By 50%. So there's been, compared to the national trend, there's been an uptick, an acceleration in general suicide in Oregon. So it certainly hasn't prevented people from suicide. It may indeed be causing a contagion effect, which is actually a thing. All right, so I'm going to close with some thoughts about why this is not a good idea. Uh, First of all, there are always other options. Palliative care is underfunded, as we see in the United States, underfunded, undertrained, underavailable, generally misunderstood, not just by patients and the general population, but by clinicians. It's inconsistent because it creates an uneven application of suicide prevention. Some are allowed suicide, some are not allowed suicide. The two tiers of suicide, the moral outsourcing, the inconsistency. Also, there's a lot of talk about, the patient's choice, but it's a kind of pseudo choice because the choice is forced by having fewer choices in other domains. Many people are choosing this who have fewer economic choices, less access to palliative care, inadequate mental health services, and also, at the end of the day, it's not the patient's choice. It's the doctor's choice. The doctor decides whether they agree that this person is eligible or not. Is their suffering qualifies, their terminality exists or doesn't exist, that their case is futile or not futile. So it's not the patient's choice. It really still is in the hands of the physician. We've seen the inevitable expansions, the slippery slope that safeguards do not hold. And once introduced, there always are understandable ethical and legal reasons for progressive expansions. This undermines millennia of medical ethics. The physician is a healer, bringer of comfort and support in the face of death. We can step out of the way of the death. We can provide comfort, palliative comfort, but not actively administer or abet suicide. We've talked about the problem of moral outsourcing, and this elevates autonomy as an exclusive moral principle over all other principles that a civilized society has to embrace in addressing the common good. That's kind of my elevator speech list of all of these issues, which I could give you, an entire hour on each of those issues. So in closing, I'm going to quote a couple of my intellectual heroes. Leo Tolstoy says, "Wrong does not cease to be wrong because the majority share in it." Here in the US, Edward Livingston Trudeau, who founded one of our most important TB labs, famously said that the job of the physician is to cure sometimes, to relieve often, to comfort always, and to kill never. That's what it means to be a physician and has meant since the Hippocratic Oath, which said, I will not administer a poison to anyone nor teach anyone else how to do so. Uh, in the UK, your C.S. Lewis said, we all want progress, but if you're on the right road, progress means doing an about turn and walk. I'm sorry, if you're on the wrong road, progress means doing an about turn and walking back to the right road. In that case, the man who turns back soonest is the most progressive. And the founder of the hospice movement, your Dem Cicely Saunders, said, if nothing can be done, there is still a lot to do. And there is still more that you all can do as you all stand on the verge of a very profound and fundamental change in what it means to be a physician in your country. And the folks at our duty of care will help guide you practically about what you can do at this point. Thank you very much.